Ladies and gentlemen, welcome back to the Rooted Mama podcast. Today we are joined by another special guest. Her name is Samantha, and she is a nurse in the Neonatal Intensive Care Unit, which is also known as the NICU. She's also getting her master's degree in nursing education, and once y'all listen to this episode, you will be very happy knowing that Samantha is the one out there teaching future nurses because she is absolutely an amazing nurse. To be honest with you, I was really excited for this episode because NICU is something that is very scary. It's something that no mother wants to have happen to them. Like, no mother wants their baby to go into the NICU. It's a very scary place. And Samantha did a great job explaining just how much NICU nurses care about their patients, about the parents of the patients, and how much they work to get those babies healthy and out the door and into the hands of their parents. So I can't wait for y'all to hear this episode. It's definitely going to bless you. It's going to teach you. But before we do that, I do have two quick reminders. The first one is if you're someone who's enjoying these episodes, it would mean so much if you followed, left a review, rated it 5 stars, or shared it with someone else that you know that you think would really enjoy this content. And second, if you're looking for ways to support the podcast financially, I don't run any ads, but I do provide digital products that are easy to download and available on my website. So I'll link that in the show notes. All right, let's get into the episode. All right, Samantha, welcome to the podcast.
Hi, thanks for having me.
So I'm super excited to have you on because you are a NICU nurse, but you also are in school to be a teacher of nurses. Is that correct?
Yeah, so it's a master's degree in nursing education. So essentially, if you wanted to be a professor in a nursing program, just having your nursing degree, or not your nursing, sorry, your education degree isn't enough. You have to be a registered nurse, but then you also need to have a advanced degree in nursing education. So it's kind of like a mixture, a beautiful melting pot of both sides of advanced nursing practice, but also focus on education and how we can really just prepare the next up and coming nurses in our workforce.
I love it. So you are going to be able to educate us like big time on all the things. And I have so many questions for you, but the first one is pretty simple, I promise. Can you tell us a little bit about yourself?
Sure. So I am originally from Connecticut. I was born and raised there. I went to high school, college, all the things. At the time when I graduated nursing school, there was a huge healthcare cut at the time where unless you were already a PCT or like a CNA, they like to
What
call
are
them in
those things
Connecticut.
for the
Sorry. So, a PCT down where I'm from now is a patient care technician,
Okay.
but you have a CNA license, which is a certified nursing assistant. Back in
Mhm.
Connecticut, you usually were called CNAs. And then when I
Yes.
moved down to Florida, they're like, oh, PCTs. I was like, well, what is that? They're like, it's the same thing. So, unless you were already working as a tech or as a nursing assistant in a hospital, a lot of the hospitals didn't want to hire a new grad that was outside of that
Hmm.
hospital already because it costs so much money for hospital orientation and onboarding. And it was just like something that was going on at the time
Wow.
with the government in Connecticut. So, and what I was looking into, so during my time in nursing school, I had somewhat of a crisis halfway through my nursing program. So I'm going through these clinicals. I've always known I wanted to be a nurse. I love helping people. I was always like that mama hen in high school that I was like always DD and I was taking care of everybody after even parties in college and things like that. Like it's just like I love to take care of people.
Yeah.
But then as I was going through nursing school, I was realizing going through my clinicals that I was like, man, like I love this profession, but I just don't know what type of specialty in adult or even general med surge. Like I didn't feel it ignite in me. And I remember my professor just telling me to take a deep breath. I was probably a peds person, pediatrics. She's like, we see this all the time, people second guessing nursing. You haven't hit your OB and peds rotation, which is obstetrics and pediatrics.
Hmm.
And she's like, just give it time. It's next semester. Like it, just because you don't feel it in your clinicals doesn't mean you're not where you're supposed to be. So I did my OB and my peds rotation and I loved it. I was like, oh my gosh, this is the feeling I was looking for. And then I remember my first time in pediatrics, we would we'd mainly be in pediatric med surg, but then we would have a day in the PICU, Pediatric Intensive Care Unit, a day in the NICU, the Neonatal Intensive Care Unit. We did a day on pediatric hemonc, which is hematology oncology, just to see the specialties.
Yeah.
And I just remember my day in the NICU, like going. And I was like, you got, I don't want to leave. Like, can I just stay for night shift? Can I
Oh,
just stay here and absorb it more? So that really was like, oh my gosh, like I didn't want to go home. I
yeah.
wasn't like, when is clinical over? You know, let's get post conference over with, all that. So was like, oh my gosh. I was like, I started deep diving and seeing if I could shadow or volunteer or just anything to get that exposure. And then they were able to allow me to do my senior preceptorship, or a senior practicum. Different
Mm-hmm.
nursing schools call it different things. So I was able to do my senior practicum preceptorship in a neonatal ICU in Connecticut, which was
Mm.
so amazing. And that really solidified for me that I'm like, this to me, like, I don't know where your listeners are and all that, but for me, like, that was God's calling to me, that I was like, I am meant to be in the NICU, like, heart burns for it. I'd go to clinical and I just was like, I want to come back. I want to see how the kids are doing. Like the next week, I was so emotionally, mentally invested in wanting to just know more about how I could care for these kids.
Yeah.
And then
Wait,
so,
so okay, I have to say this. Like whenever
yeah,
and we're gonna get into like I'm asking you all the questions about the
yeah.
NICU, but when I think about it, and this is probably because I'm not a nurse and because I'm not in medicine, but like
Uh-huh.
NICU seems like stressful and scary. Like babies are sick and like that's what we hear from the outside. And so I
hmm
just automatically just wonder like what for you, like that didn't scare you? Like that didn't deter you that they were like the sickest babies?
No,
Okay.
it's funny, even now, people will say, we're all a bunch of nurses in a herd. Oh my God, where do you work? Where do you work? And as soon as I say NICU, they're like, oh, I could never do what you do. Never in a million
Wow.
years. And I'm like, well, I give you kudos because you're dealing with the adults, that
Yeah.
have COPD and all these things because they couldn't stop smoking cigarettes, all these things. I'm like,
Yeah.
I give you kudos because I think also the biggest thing, I think going back to being in nursing school, they say that a nurse is so many things. We are a caretaker, but we are also an advocate. We are a teacher. We are all these things because so much of nursing in general, as a bedside nurse, is education.
Mm.
And I would see in my clinicals, you know, I would even, I mean, I was a student nurse, right? They probably were like, okay, let this girl talk, but, let her practice her patient education. But it just wasn't as well received and appreciated by the adults,
Mm.
or I would teach them and I would say stuff and I would be like, teach back, like, let me know that you understood. And then it's like, I would check in and they'd be there like the next week and they would have totally disregarded. And they're like, oh, I wasn't really paying attention. And it's hard because when you are passionate about something, to know that your efforts didn't make a difference, it takes a hit, right? And
Yeah.
that's how the world is, though. Not everyone's going to listen to you when you speak, and I've come to terms with that. But
Yeah.
then when I was in pediatrics and specifically in the NICU, when you're teaching these parents and you're educating them and you're empowering them with the knowledge to help them feel more confident about what's going on with their baby, or hey, like, let's work with physical therapy, occupational therapy, learn these massages and stretches to help them as they grow through this prematurity. And they're like eager to learn, right?
Mm.
They want to just soak it all up. They want the videos, all of that just felt so empowering to me. And though I understand no matter where you are as a nurse, what we do makes a difference, it just felt exponentially more
Mm.
impactful in the NICU. So that too, like the side of me, right? Because I'm going into my master's for nursing education now. The
Yeah.
teacher side of me, where I love teaching people about anything that I know of that I can like expand, like
You've
send my
always been
knowledge
this
over to.
way.
I've always been this way. I've kind of been hardwired. I'm like, oh, you don't know how to do it? Let me show you. I get so excited teaching people new things. And
Yes.
uh So I feel like that's always been in me, and knowing that neonatal nursing really fulfilled both my caretaking, that first of all, I love babies. I'm like, they can do no wrong. Like, even when they are on their worst behavior some days, because I'm like, I know you don't feel good and you can't tell me, right? But
Yeah.
it's just also just that teaching, like empowering families and helping them through what most likely up until that date is the scariest point in their lives. Like,
Yeah.
making that difference, even long term, and getting to see them go home, just nothing fills my cup more. Nothing.
Oh, that's so special. I love that.
Yeah.
And I could see I love talking to people when they're doing what God created them to do. Like you could just
Hmm.
tell there's a difference there when they're operating in their spiritual gifts, and it's evident that that's what you're doing. So let's get into it. Okay, so what is a day in the life of a NICU nurse like? Like give us, I mean, there are people like me. I'm the
Hmm.
person. I'm people. I have
Hmm.
no idea. I'm blessed. I don't have children. I didn't have children that were in the NICU. I don't know any family members. I have one friend who had a child there for just a few days, but like it's
Hmm.
totally foreign to me. And as I said, I'm coming from this place of fear, right? So I would love
Right.
if you just kind of like broke it down to, what it's like, what goes on, what's life like there.
Yeah. Yeah. Absolutely. So first, I want to preface and say that there's different levels to the NICUs. So,
Perfect. Let us know.
so, so you could have a level two, right? There's really no level one. Level one is just like a special care nursery. You could have like a level two, a level three, and a level four. And the number of beds, just like how you have hospitals that are like a 400-bed hospital or a 1,000-bed hospital, how many beds your NICU is as well, um, sometimes can change what your day to day looks like. The demographics around you, also, what kind of moms you're seeing is going to be a big indicator or a factor that is going to affect what you're seeing as a NICU nurse in that NICU. A hospital that I work at now, we are a level one trauma center. We are well known. We're top 10 in the country for obstetrics and gynecology. So we are seeing all of those high risk maternal fetal medicine patients,
Mm,
moms that are at risk for these very dangerous deliveries or the baby's not doing well. So in my sense, I we are getting all of these high risk deliveries. So we are seeing a very large amount of preterm babies. Whereas I'll
okay.
be honest, if you go to hospital maybe 30 to 50 miles north from here. And it's like a smaller, maybe a little bit more of a rural hospital, but they have a level two NICU. That day to day is going to look a little different
Okay.
just because the patients they're able to take, or if a baby is born there. I mean, if you get a baby who's extremely preterm, is born at like 24 or 25 weeks, they would, I mean, in emergency, every NICU knows what to do for initial
Mm,
resuscitation, but then they would call a tertiary center like us, and then we would fly out and go pick up the baby and bring it to us.
mm,
So, I've worked in my same unit for 12 years, and I've grown there since being a new grad up until where I am now. So I can only speak to working in my level of a unit.
yeah.
We are a much larger unit. There are some NICUs that, when I did my senior preceptorship, I want to say it was maybe, if I'm remembering correctly, maybe 20 beds, 15 or 20 beds. And my NICU is 80 to 90 beds.
Oh my
So
goodness.
we, yeah.
That's
So
huge.
we, I mean, listen, talking about Texas, I mean, Texas Children's is like over 100. So we're up there with some of the biggest NICUs, but we're not like the biggest. There's
Yeah.
others in like Orlando. Winnie Palmer is huge. Florida's Orlando Advent, huge.
Mm.
Or yeah, like it used to be Orlando Health, now
You
it's
know
Advent.
what? It's so
But
I have to cut you off because like it's so weird that I actually interviewed a nurse from Texas Children's. Like
yeah,
yeah, yeah, she's APRN and she works
okay.
with heart babies. specifically,
Okay, so she's on the cardiac unit.
but we didn't talk about. I mean, she obviously goes into the NICU, but
Hmm.
we didn't talk about it at all because you're here. But yeah, the fact that you mentioned Texas Children, so I'm like,
Texas Children's is
yeah,
amazing.
I'm interviewing
Amazing.
some heavy hitting medical professionals on this podcast. You guys are lucky
That's
listeners, okay?
oh
Okay,
my
go
gosh,
on.
yeah, there's so many top tier children's hospitals in the country. And the cool thing about NICU, neonatal ICU, is that it's a small world. So like when you get to know people, you get to know, especially when you start going to conferences, you'll say like, "Oh my gosh, like um I know a nurse in that NICU," right? So like even though there are so many in the country, it's just like this little sweet family society that just is so close knit because we are like-minded people. We are people that love these babies and these families so much. It's very niche. It's a specialty form of healthcare. It's not just like, oh, I'm a doctor. Oh, no, I'm a pediatrician. No, you're a neonatologist, right? So you are
Mm,
specially trained. Like these attending physicians that are called neonatologists, I mean, they go through residency and then they have to do 4 years of residency, then they have to do 3 years of fellowship, and then they can sit for their boards, and that's 7 years on top of whatever they've already done in medical school, right?
yeah.
So, um,
What is a, because you mentioned some of the cases, you said like premature babies, but like, what are some of the common reasons that a baby would be admitted to the NICU?
you basically have, if you're preterm, and this is pretty much standard across all the country. If you're born less than 35 weeks, it's an automatic admission to the NICU,
Okay.
regardless, even if you're like on room air, breathing well, maintaining your temperature, like doing all the things, right? If you're less than 35 weeks, it's an automatic admission to the NICU. You may not stay for very long, but it's more of just a way if you're that late, like a late preterm, keeping an eye, right? Because even though everything looks perfectly formed, everything, you're like, they can do all the things. They can, breastfeed, they can take a bottle, all of that. We still have to know that really that last month of your pregnancy, from 35 to 39, 36 to 40 weeks, right? That is where, though everything is developed, all that fine tuning, maturation, that detail work in our bodies, in our brains, in our lungs, in our gut, all of that is happening in that last month. So, understanding that if a baby is born under 35 weeks, though they have the opportunity to do everything they need to do, we know that they may struggle with thermoregulation, keeping their body warm without some extra help from maybe an overhead warmer.
Mm.
Or, they really the suck, swallow, breathe coordination, knowing that when you're taking, whether it's breastfeeding or taking a bottle, knowing to suck on, the nipple and then swallow, but then also pause to breathe, that coordination and having it nailed down really doesn't come full circle for a baby, where I like to tell parents the light bulb is flickering. It goes full on at 37 weeks for that.
Mm.
So we even have some babies, aside from premature, if you have a term baby that comes to us, there could be a host of reasons. Either maybe they were on the floor and their bilirubin starts to go up. So they
What do
might
you
need
mean like
some,
on the floor?
sorry, postpartum. I should say
Oh,
after you have a
okay.
baby.
I feel
Sorry.
like they were on the floor.
On the floor, they're just laying there. Sorry. So that's just like, we're always like, we're getting a baby from the floor, but it's not like,
Yeah, when you just said that, I'm like, she said it so calmly. I'm like,
I'm so sorry. This is, you got to catch me, right? Because that's the
okay,
only trouble is sometimes I just speak in lingo and I'm like, I gotta, I, I gotta remember there's people that may not be medical.
yes, we are
Um,
not.
So postpartum, so they always say like after you deliver, at least in mine, there's some hospitals that have LDRPs, which is labor delivery recovery postpartum rooms. So they labor in their room, they deliver in their room, and they stay there for postpartum for
Mm.
recovery, and then they discharge from that room. So it's all one situation. At my hospital, we have laboring rooms, we have triage, OR, laboring rooms, but then after for 2 hours, you're watched, you're made sure everything is okay with mom and baby. Then you're brought over to the postpartum floors. And
Okay.
that's where we'll like, oh yeah, mom and baby are going to the floor. Or, and we know they're out on the floor. It just means like in our language they're in the postpartum unit. So
Okay.
a baby sometimes can be born completely fine, transitioning well. That fetal circulation when they're in mom's uterus, and then transitioning to neonatal circulation, all the pressure changes that happen. Some babies transition very well, all is all is copacetic, and then they can go with mommy out to postpartum. But then sometimes they have difficulty transitioning. So sometimes they come to the NICU for like 4 hours as a transition to just make sure that our breathing gets regulated, all of that. Maybe they were on the postpartum floor and their bilirubin started to build up, and that's something that's made in our body that normally is excreted. But when you're a little bit premature, or even truly if you're full term, depending what genetic things you have going on, even just like certain ethnicities too, they just have a higher risk of having hyperbilirubinemia, is what it's called when there's too high of a bilirubin level in your blood. And you need phototherapy to break down that bilirubin using those UV rays and all that. Sometimes it could be totally healthy baby, but they just have to come to us for that phototherapy treatment.
Mm,
And then you have some babies that just are born term, but they just have a really rough delivery for whatever reason. Is it because mom had a prolapsed umbilical cord? Was it that, she was a placenta previa and all of a sudden we didn't know it? And now we're, just little things like that can
yeah.
happen. And then baby has a little bit of a difficult delivery and then needs some resuscitation. And then
Mm,
they'll come to us for that too. So we see, I would say, of our total population, I would say 60 to 70% are preterm, and then the other 30 to 40%, depending on the season we're in, are going to be term babies that just need help in some way, whether it's
okay.
something as stable as receiving phototherapy treatment, or if they needed some breathing treatments like CPAP after birth. If there's sugars, if mom was diabetic and wasn't able to control her sugars well, sometimes those babies need to come to us for IV fluids because I don't want to get too into the medical unless you want me to, but it has to do with their insulin levels and all of this, and it crashes their sugars out.
Okay.
So they sometimes have to come to us just to get some dextrose fluid again to help them settle out, and then that way they can get ready to go home. So we really see a varying amount of diagnoses, I should say, and gestational ages that come to us, but the majority is going to be preterm.
Okay. So you were talking about like the percentages, and it sounds like it's lower for like those babies born at term, like the chance. I guess I'm bringing it up because like there is a fear. I'm operating from fear, and like there's a fear out there
Hmm.
from mothers. Like anything could happen in your birth, and then the baby
Yeah.
might die, and like all these like all this fear. But you kind of like made me comfortable at least because you're saying like most of the time the babies that are born like full term like a norm they're less often in the
Hmm.
NICU than a preterm baby, which makes sense. Like a
Yeah.
preterm baby is probably going to need more help. And so that was like a little bit comforting to me, at least to hear that. And then that kind of leads me to the next question, which is how long are babies typically in the NICU for? And I know that's like a rough question because it's so variable, but like generally, how long would you see a baby who's full term? Let's do this because we know like a baby who's preterm is going to be there longer. But a baby who's full term who comes in, they had a difficult delivery or something like that, how long are they typically there for?
So I think that's the hardest thing about the NICU. Nobody, first, let me say this, no mom anticipates I'm going to have my baby and we're going to make a pit stop in the NICU. We're going to make some extra friends. We're going to network, right? That's never anyone's plan. So we automatically, and I teach all my girls and guys that decide to come to NICU. I teach all my new nurses, you have to first be in a headspace to understand none of these parents want to be here. They
Yeah.
don't. And if you can put yourself mentally in their shoes, I feel like you can prepare for conversations a little bit easier, understand where they're coming from and how they're feeling. And it's hard, right? Because I always like to say, like, let's say baby's name is Liam. I don't know. Let's just pick a name, a random name. And I always like to tell them this is the criteria that needs to be met for them to leave the NICU. They need to be breathing on their own, room air. not having any oxygen desaturations drop in their saturations of oxygen, not having any drops in heart rate. They need to be vitals totally stable, no increased work of breathing, breathing on room air. They also need to be eating, whether that's breastfeeding or bottle feeding. And then they also need to be gaining weight because, oh, and maintaining their body temperature. So, maintaining your body temperature, breathing at a normal rate, unlabored, eating, all those things are attacks on our body's metabolic system. So, if we know that the baby can do all these things and still gain weight, that means that we are in a good place and baby can go home, right? So, a lot of parents are like, well, how big do they have to be? Or is it a 7 day stay? And I always like
Mm,
to just say it's milestones. If we can do these four things, check off the boxes, your baby can go home. And people will say, well, then how long will that take? Because a lot of times they're like, oh, when they hit 4 pounds or when they hit 5 pounds. I'm like, it's not. I've sent home 4 pound babies in special car seats that
mm,
were rock stars, able to do all the things, had some fetal growth restriction, which just means for whatever reason in mom's uterus, they just never grew to their fullest potential for their gestational age. So it's not a body measurement thing at all. And I have some babies that are with us for 2 days that were term and just needed to have some time to get themselves straightened out. And then I've had term kids come that were with us for 3 weeks, 4 weeks. It's so hard to say. And that is something that I think puts more anxiety on the family because there's a loss of control. And I know, and that's what I teach my team. We chose neonatal ICU. We chose to do what we're doing, right? But imagine putting yourself in a situation and it's your loved one, your baby, right? And they can tell you all the things and make you feel comfortable. But then when you're like, okay, like I feel good. So, but then like, when do we think we're going to go home? And to hear, I don't know, or like maybe 5 days. I always tell my team overestimate because I would much rather be able to celebrate with a parent and be like, oh my gosh, we thought it was going to be 7 days and baby Liam's getting to go home in 4 days. We want to celebrate that. What I don't want to do is I always tell my team, don't tell a parent that, hey, yeah, you know what? I think by Saturday, amazing. Like,
yeah,
gonna get him home, let the grandparents know, fly in, and it doesn't happen. What happens is we end up looking like the bad guy.
yeah,
And I like to say, like, I'm still going to use the name Liam. I always like to say, this is Liam's world and we are living in it and we are doing what Liam needs.
yeah,
If Liam says he needs more time learning how to breathe and eat, we're going to focus on that. If Liam needs a little bit more time to figure out how to stabilize his temperatures, we're going to work on that, right? Because at the end of the day, we want your baby to go home as safe as possible. We want to make sure that there's no questions or doubts being like, well, I hope they don't do this again. I hope they're not going to choke on their feeds,
mm,
right? So, as much as it's hard, because in that waiting season, no matter if you're waiting for something outside of medical care, right? If you're in a waiting season, you're waiting for a loved one to be discharged from the hospital, it's hard and it gets frustrating. And they're like, I just want to take them home.
yeah,
I try so hard to tell the parents, I want you to know that I'm not trying to keep your baby here. I don't, I love your baby and I will be the best nurse to your baby when you're not here. But please know that I'm not trying to further his stay. I
yeah.
want to make sure that when you come home or when you go home with him, you don't have to come back for a readmission, that everything is perfect. So, um,
That's a good
it's
answer.
so hard.
No,
It's so hard to
it's a
nail
valid
down.
answer because you were saying it's
Yeah.
not about the time, it's about their ability to maintain health, which is the goal,
Hmm.
right? That's the overall
Right.
goal. And as you're talking, it does bring up an important point that I was, you know, trying to figure out how to ask, and you brought it up naturally that this is a heightened emotional environment. Like there's no other way around it, right? Like the emotions are big because a baby is born, number one, and that's an important day in everyone's life. But then on top of that, you have to deal with a parent has to deal with the grief of it not working out the way that they probably hoped. For most parents, they don't know the baby's going into an ICU, right? They're not thinking that. But then also it's a loss of Literally, like you said, control. So there's like, I can't celebrate really. Like, I can't celebrate fully. I can't take my baby home, and I have no idea when it's going to happen. So there's like so many emotions there on top of a mother who's newly postpartum, right? So
That alone, that
that's
alone.
enough. That's enough.
Mm-hmm.
So if you're a mom, if you're talking to a mom who,
Mm-hmm.
like, who would be like me, never experienced this before, um, what would be things to expect during her baby's NICU stay? Like, from her perspective, like what is required of her? What is she going to see like day to day? And what kind of things does she need to do as the mother?
So I think it also depends on family dynamics, right? Because we also never want to put pressure on a mom to feel guilty. So the biggest thing I would say is if a mom is still in the hospital and her baby is in NICU, we advocate two things. Number one, her well-being is the most important, and I always like just try to hammer that into their heads. I know you want to be here for your baby, but you also need to take care of yourself because you just went, like, it's his birthday, but it's your birthday. Like,
Right.
you gave birth. That is incredibly traumatic for the body. That is hugely stressful. So we don't put expectations on our moms to be like, okay, like, to be a great NICU mom, you have to do X, Y, and Z,
Mm,
right? So we try to meet them first where they're at. If this is a mom, like, I had two very different cases in the last couple of weeks. I had one mom that she would come to the room while she was still inpatient, maybe once a day to come see her baby. And she's like, I brought milk, I pumped. I'm like, phenomenal. She's like, and she cried. She's like, I want to come over here and spend more time. I'm just so tired. And I said, you are doing amazing. You are taking care of you. While you take care of you, I'm taking care of him, right?
yeah.
You coming to see him, I like to say, let me say this. For anyone who isn't medical, but if they know of anybody who has ever had Alzheimer's, right? And I know this sounds super strange, hear me out. Babies to me sometimes are like Alzheimer's patients in this fact. They are not aware that you aren't there, but when you are, they feel immense joy. They have that
Mm,
bonding, right? So, just like an older person with Alzheimer's, they live for those moments of joy, and we can't ever tell if they're cognizantly aware that that person that they wish were there actually isn't there. Babies
mm,
are the same way. So I said, I try to take that stress off the mom. I'm like, if you can't be here because you need to take care of yourself, lay down, take a nap, take a warm shower, handle yourself with whatever pain meds they want to give you. I don't want you to think that your baby knows you're not here because
mm.
they probably don't. Is there that innate desire for a baby, obviously, to be close to their mom?
Yeah, of
Absolutely.
course.
And we foster that bonding. I tell mom, I said, if you want to just live over here, I'll tell your nurse I'm postpartum. You call me when she needs to come back for vitals, medications, what have you. But mommy really wants to spend the most of her time here, then we honor that and we support that. Do as
Yeah.
much skin to skin as possible. Pumping is amazing if your baby is too premature to breastfeed. That is amazing, all those things. But then there's also going to be those babies that maybe they can't be held skin to skin right away because they are unstable and they're really
Mm,
sick. So then we tell these moms, you know what, though, they can still feel your presence. Go in there, just put your hand over them, and we like to call them hand hugs, right? Because
mm,
preterm babies, um, being premature, their developmental systems, they cannot handle sensory things as well, which is why we always
mm.
have like the lights dark. We have the door closed, not because we're mimicking the uterus, right?
Yeah.
Dark. They're in humidified incubators. When you put your hands on them, we always emphasize hand hugs because if you stroke a baby's, like, their feet, or even like you're rubbing their arm or their chest, the stroking can elicit pain in a preterm child
Wow.
because the pain receptors, their skin,
Yeah,
everything
I
is
mean, it
so
makes
totally
sense.
different.
They weren't ready to be touched yet. Not
Right.
that way anyway. Yeah.
hmm So then I emphasize, still, here's how you can bond. Make sure we're nice and sanitized. And then just putting your hand over, just like like, not firm, but like
Yeah.
they know your smell. You smell
Mm,
like the amniotic fluid that they were in. They know. We tell parents to put like these scent patches. They're oh my gosh, the material is losing me. I'm having a brain block in this moment.
like
But it's not
silicone or
felt.
something? Oh.
No, it's more of like a fabric that they can put on them, and then we put it next to the baby so they can smell mom.
Oh, I love that.
Um, doing things like that.
Years ago, when I first decided I wanted to become the best version of myself, I went out and bought this beautifully designed guided mental health journal. I was so ready to change my life, y'all. But when I got home, I looked around my apartment and every table was covered in junk. Like, I'm not kidding. Like, every table was covered in junk. So I couldn't even write on this journal, even if I wanted to. I didn't even have a clear space to sit down and write. And that moment really hit me hard because before I could grow into the person I wanted to be, I needed some simple first steps just to get my life together. That's exactly why I created the Daily Survival Planner. It's a starting place. Practical, doable strategies to help you organize your daily life so the deeper healing has room, literally room, to actually happen. You can find it in the show notes, and podcast listeners get a special discount.
I don't want any mom that has to come to the NICU to ever feel like there's a certain thing they have to do. We meet them where they're at. You want to be here and you feel well enough. Here's all the things you can do to support your baby, and we can help bond and do all those things. But if you need to take care of yourself, all I'm
Which you
going to tell
do.
you to do is take care of yourself. And, we do recommend pumping, especially because if the baby was preterm, I mean, for all babies, breast milk is
Yeah.
top-notch gold standard, right? It's customizable nutrition that we could spend a whole other hour going on about how amazing breast milk is
Yeah.
and what our bodies do for these babies. But I just like to say what you can do for your baby if you need to lay in your bed longer is just if pumping and breastfeeding is we educate as much as we can. There are going to be some moms, it's rare, but there are some moms, no matter how much we educate, they still opt to just be like, I'd want to use donor milk for now. I don't want to breastfeed. I don't want to produce milk. I want to do donor milk until it's safe to do formula. And we educate, but then we honor. We honor
Yeah.
decisions, and all of that. It's about empowering the mom to do what's best for her and the baby.
Right, right.
Um, so it's also kind of a loaded question. I can't sit here and tell you there's a standardized
Hmm.
checklist in what to do as a NICU mom. I think the best thing to do is to just be open in communication with your medical team, with your bedside nurses, to just be like, this is where I'm at. I feel well enough. What can I do? Is the baby okay for me to hold them and do skin to skin and do all these things? 9 times out of 10, the answer is going to be yes. There's going to be a few exceptions every now and then if the baby has a lot going on, if there's, like is on like a certain type of ventilator, if they have like an arterial line in their umbilical cord, just certain things that maybe we're trying our best in this moment to give the medical care to the baby. So how can we promote this bonding in another way?
Yeah.
Um, but
How do
just
you guys feed the babies when they're so small like that? Like if they can't, if they can't come out, like if the mom is pumping and the baby can take milk, right? Because I know babies
hmm,
are fed through tubes and stuff, but like if they can
yes.
take milk, then how do you give it to them?
So we have nasal oral tubes, and they look, let me first preface by saying they look way scarier on adults and children because when I go somewhere and you see it like hanging out of a person's nose, you're like, no, like that seems
Yeah.
so scary. But the ones for these babies are so, so tiny. And parents are always like, oh my gosh, is it going to hurt? I always say, literally, it is, especially when we put it if they're not on oxygen and they need help with their feedings, if they're just getting too tired, we want to make sure that they're not aspirating, right? We're
Mm-hmm.
not going to force a baby to breastfeed or bottle feed if they are having this increased energy expenditure that's going to cause them to get quote unquote a little bit lazier in feeding and then
Mm-hmm.
possibly aspirate. We're going to prevent that from happening. So we're looking at feeding cues. We're looking at, um, you know, satiety scores. When is baby saying they're done with their feed?
Mm.
So if they're not on any sort of oxygen, then we will usually put a little NG tube, a nasogastric tube, up in their nose, and it's Textbook every time. I'm like, the baby's gonna sneeze twice. And then once it's in and that tube goes into their nose, we usually tape it across their cheek and then it goes down to
Oh,
their stomach.
okay. Yes.
Yep, so it usually
I
just is
see the
here.
babies with
It
the
gets
stuff on
taped
their
across
face.
their cheek, and it's just like a little tube here that we can access either hang by gravity, so the milk goes in on its own when the stomach
Oh.
can, or if a baby's having like sugar issues or maybe just needs it to go in a little bit slower, then we can put it over a feeding pump, which just means we hook up the syringe, the amount of milk that they need, to a pump, and it just makes sure that it goes in a little bit at a time.
Hmm.
And gravity feeds can do that too, depending on where you hang it, what size tube, and all that.
Yeah.
It's technical, but so they'll either have an NG tube or what we call an OG, which is orogastric, and it's the same thing. It's a tube that goes to their tummy,
Hmm.
and we can administer milk, PO medications, PO meaning by mouth, um, and or formula, whatever it is that the baby's eating. So NG or OG, and then sometimes there's always the possibility too is as a baby gets older, if they're really just not eating well, it's a last case scenario. We never want to do it, but then there are gastrostomy tubes, which is when they have that little button just right over the surface of their stomach, and that's a surgery that's placed for that. So those are the
Hmm.
three ways that we can enterally feed babies, meaning that we're feeding them with some sort of food source, breast milk formula, things like that. So, and the NG and OG can be taken out easily, no big deal. The G tube, a gastrostomy tube, again, that's not something that we do for preemies right out the gate. That is like we've given them, they're 5 or 6 months old. We still can't quite, whether they have like an oral aversion or there's something going on with them, whether it be like a genetic defect and
Hmm.
or if there's something wrong with their palate, a host of things. That is the other way that you could have a baby be fed as well.
Hmm.
But we really focus on oral feeding. As soon as a baby is ready, we do that. We'll even do non-nutritive breastfeeding. So even if we're having babies practice breastfeeding, we will have the tube, the feeding NG. We will have that hooked up and we will put baby to breast. So mom will have pumped, even though they're not strong enough to breastfeed. Well, mom will have pumped milk fresh, and then
Okay.
we'll put baby on to latch and then with the feeding going at the same time so they are neurodevelopmentally connecting. I'm suckling on
Yeah.
mommy's breast and my tummy is filling at the same time, right? So connecting
Hmm.
those pathways, similar for our preterms when they're getting their tube feeds, we usually offer them a pacifier because we want them to connect sucking with their belly filling.
Okay.
So there's a lot of things we try to do to help them developmentally just grow.
Right. Because they have to learn, right? Like if they're getting
Mhm.
the tube feeds and then suddenly you're like he's strong enough now, like all right, see you later, like you have to have a transition, right? Like he has to learn.
Yep.
Well, every baby has to learn, right? Like when they're born they do have the instinct to feed, but
Hmm.
even I'm thinking about my kids. I mean, there's a learning curve still, for feeding, just for like
Oh,
any
for
baby,
sure.
right? So they have to learn, and there's like all these other parts to it too, if they have like
Hmm.
oral restrictions and all these other things. So that's really cool to hear how y'all, like figure out how to transition the baby and train mom and baby to be able to go home, even for like short stays. I'm sure you have to kind of like practice some of these things to make sure that the baby can feed and like
Hmm.
maintain their health in every way. Very cool.
Yeah, I mean, there's even like some babies that come to us. Like, I actually just had a case where mom was a C-section, and babies that are born from C-section always have a little bit of a higher chance to coming to us to transition because if they're not delivered vaginally, they really don't have that squeeze out of all the fluid that
Mm,
may be in their lungs and their tummy and all that. And that's not to say I don't say that to make a mom feel anything less for getting a C-section. The most important thing is to deliver your baby safely and health-wise what's best for mom and baby. And for some situations, that is C-sections.
right.
But so a baby with a C-section sometimes could be at a little bit of a higher risk for just having a little bit more of a respiratory distress if there's some leftover fluid that needs to be suctioned out. But so we had this mom who was a C-section, but she also had something that was called polyhydramnios, which means
Mm,
that the normal amount of amniotic fluid that should be there, she had more, right? So when babies are in this environment, and then also having a C-section. This baby, um, you know, came to us because he had a low cord gas, which is something, again, basically they look at blood gas for babies from the umbilical cord just to make sure their pH looks okay, all the things that I don't want to like dive too into because it's
Yes.
not a medical um, a medical discussion. Um, but anyway, so this baby came to us for transition to make sure because the blood gas kind of showed us, well, he may struggle to breathe a little bit. He might be okay. It's kind of Russian roulette. Some babies do fine and others need help. Well, he ended up needing a little bit of help. Went on some CPAP for a little bit, which is similar to like on adults, just when you see a mask on them and they're not intubated, right?
Hmm.
Not a tube going into their lungs. It's a mask. It gives continuous positive airway pressure. It really just helps to keep their lungs open. I like to say if you had a completely deflated balloon and you try to blow it up, right, it takes a lot of effort. But if
Mm.
you had an inflated balloon that you let like half the air out and then you go to reinflate it, it's much easier. That
That
pressure we're
makes
giving them is
sense.
to help keep their lungs partially inflated to make when they breathe on their own easier. So this baby needed some help. And then the next morning when I had him, we were able to take him off the CPAP and he was doing okay. But he kept vomiting just extra fluid from delivery. So that made it
Mm.
difficult. He didn't really want to bottle feed or breastfeed because there was that negative association with the vomiting, right? And
Yeah.
sometimes because when he would go to try to eat, because the food went down, and then the breast milk went down, but then he
Hmm.
would regurgitate it because we're trying to get all this excess fluid out of his stomach, right?
Wow.
So
Yes.
then those babies, we need to tell mom, like, listen, we may be here for a couple more days to make sure all that fluid gets out. And we want to make sure we work with him on his feeding because we don't want any sort of oral aversion to
Right.
happen. So while we're getting all this fluid out, we may need to just do some tube feedings because we don't want him to have any negative connotation with feeding
Yeah.
and that.
Okay. This makes
So,
me think, like, do babies tend to have, what am I trying to say? Do C-section babies tend to have more reflux? Like, is that correlated at all to have like more reflux after because of the fluid? Because I've seen a few
so
friends have babies with reflux who had C-sections.
mhm. I I have to look at the data on it. I don't think there's a direct correlation because reflux could be a few things. Physiologically, they could have a weaker sphincter, which is why when the belly fills up, it refluxes. It could be something more
Mm,
neurologic going on. I wouldn't go as far to say that. I mean, could it be that they're more refluxy initially after birth because they might have a little bit more fluid that they need to get up and out? Yes, but long term, saying that when they're like 2, 3, 4 months old, they still have
yeah.
reflux. I'll be very transparent. I would have to look at data on that, but from the knowledge I have, I would say no, there is not a direct correlation to say that you have an increased risk of reflux
Like down
continuing.
the line. Yeah.
Yeah, not to my knowledge, but I also I try to keep abreast of all my nursing journals and my neonatology data.
Yeah.
We are a
Which is like
huge evidence
just light reading, like
casual,
casual in the
very
middle of.
casual. Everyone's talking about like, oh, what book are you reading? I'm like, have you guys seen the most recent like neonatology journal on blah blah blah? And people are like, okay, Sam. It's
It's
ingrained in me
so
to being in
funny.
school, but you know.
Yes. Yes. Oh my
So, and there's
gosh.
always new data coming out. I mean, it'd be
Yeah.
interesting to see if enough data was collected, you know, if there is a correlation, but to
Yeah.
my knowledge, I don't think so.
Okay. That's good. That's a good enough answer for me.
Yeah.
All right. So, wrapping up, what do you wish more mothers knew? Like, you did a great job of showing that you really care about your families, like you really care about what they need. Is there anything that you notice or see in your day to day that you
hmm
would love for more mothers to know or like take advantage of, or literally anything, ways that they could better advocate for themselves? I'll
hmm
leave the door open.
You know, I think the biggest thing to know is that there's not a one size fits all NICU journey. Some are short and sweet, and some are long and feels like a roller coaster. I would say, Mentally and emotionally, I always recommend we try to hold support groups at my hospital so that moms have the option. They're not forced, but we have some dedicated NICU psychologists, which is amazing that they are trained on how to help families through this ICU stay, that hold parent group support groups, and it just allows them to release their frustrations, to be able to feel what they're feeling and know that there's nothing wrong with that, And how you feel in the moment is never going to be wrong, right? And I tell my nurses that on my team as, I help onboard and I do all these things, is knowing that sometimes as a nurse it can be frustrating because, we have two patients. One, we are just trying our best to just give them their blood products, keep them alive, wanting to get them to that next day, get over this hurdle that they're jumping over. And then you have another baby that we're like, okay, the baby's on room air, their heart and lungs are fine, but they're here for that phototherapy treatment. And we have a mom that's like sobbing at bedside because she's like, I just
Mm,
want to take my baby out from under the lights. I want to breastfeed, but we know that the quicker we want you to have that time, but she can't be skin to skin all the time. So we're really trying to drive this lab value down, right?
yeah.
And then also knowing that there's a mom that understands that there's a potential that her child may not survive, right? And
Mm,
um my nurses, and I am guilty of it before. Like I'm always the first one to raise my hand and be like, I've been there where I just want sometimes to like look at this mom that has a baby that's doing par for the course okay and be like, oh my gosh, like, I promise I need you to trust me that if I'm not concerned and I'm telling you your baby is okay, to please believe me. Because then in my head, I'm like, I have another child that's like on the brink of death that we're so
mm,
focused on, right? But everything is so relative. It doesn't matter to that mom. That is still the worst day of her life because if
yes.
she was over on postpartum, she could pick up her baby whenever she wanted. But there she's restricted because we're under this phototherapy treatment, right?
Right.
So I try always to tell my nurses, you need to understand that it's where they're at right now, and we have to honor that. They can't possibly think about what's going on two rooms down because
Right.
to them
Right.
that's unfathomable, right? So I tell that's my advice to NICU nurses. If new ones are listening to this podcast or you're thinking about it, biggest thing is to know that not every family dynamic, not every family response is going to be the same. There's going to be anger at the situation directed at you and the medical team. There's going to be grief. There's going to be, again, because they just thought they were going to have their baby and go home. So knowing that and just meeting parents where they're at, those parents with the flat affects that you're like, they seem unbothered, but I'm worried that they're not expressing some sort of emotion. Find an outlet for them to just make sure they're okay, whether that's social work, case management, if there's a dedicated psychologist. Any sort of support you can offer them is going to be the biggest help. And then my advice to parents that have to go through a NICU stay, is just as parents are going to have different um, responses to situations, I will say there are different NICU nurses, right? We have some NICU nurses that are the ones that are sitting there, they're super seasoned and they can handle any emergency you throw at them, any baby like scenario, and they are ready to go full tilt, titrating the drips, giving the blood products, all this stuff. But knowing that they may not be the warm and cuddly and I'm
Mm,
here to do all this because they're so hyper focused on the the severity of the situation, right? And then you have some NICU nurses that I swear are built to like they want to give baths and they want to help breastfeeding, they want to do that. And there are different NICU nurses in that because there's different levels of babies of care, like level are they phase one, two, or three, right? Like what's the care acuity of them? So my biggest thing that I would give as a message to someone going through it is if you are feeling disconnected to your nurse or you're feeling scared or you're feeling unsure, just speak up. Always, always communicate. If a doctor or a nurse explains something to you and they you say like, I don't really understand, and then they tell it to you again, don't ever feel less than to just shake your head and be like, okay, and then go Google it. Please don't. Google is a scary place. Google will tell you that your headache is a neuroblastoma or some sort of tumor. Google will tell you that like I just passed some blood in my stool. You must have colon cancer. I mean, my biggest thing that I would recommend is number one, take whatever you see on the internet with a grain of salt. Trust your team and just don't be afraid to be like, I'm sorry, I'm still not understanding it. Because at the end of the day, we are here to educate and we want you to be fully informed and feel like, yes, there's going to be some medical decisions that are routine and what we have to do to treat the baby that we don't offer to parents. And we're like, listen, like we have to do this if we're going to clear the infection, right?
Mm.
But anytime we can give a parent a choice and we want them to be as involved as possible in their baby's care, we will always give them that avenue. And we always want as soon, like bonding, everything is always at the forefront for us. Don't be afraid to say you don't understand and can you explain it in a different way, right? Write things down because
It's a
if
lot.
there's something that you, it's a lot. It's a lot to process. And honestly, for any human being, whether you're going through a NICU stay or whether you are a student cramming for a nursing exam, whether you're just stuck in traffic in Los Angeles and you're frustrated and you have an important call come through, when any stressful situation is happening and our cortisol levels are high, your ability to remember cognitively things that you heard, things in high levels of stress, you need to see it, you need to read it, you need to like take it in tactile. You need to involve all the senses because cortisol really kills our ability to process. So I always tell parents like if you hear something from a doctor and you want to make sure that you're like I'm remembering it correctly or if you have a question that you have, write it down. Have a little notebook. Write down the things you want to touch on because maybe you're upset about some news you heard but you didn't quite process it, write it down. And then when you're feeling better and you're feeling up to it, come back and be like, hey, we talked about this. Can we go over this again so I can make sure I understand? Or if you're
Mm.
not with the NICU doctors and you've tried to call for an update and maybe things are bananas, because also, please, if you try to call your nurse and they're not answering, please don't think that it's because we don't want to take your call or something's going on with your baby and we're purposefully not answering. There's a firm chance that maybe everything is fine with our assignment and we're helping a nurse with another assignment because she needs help, right? So if you're ever not able to get in touch with your nurse or your medical team and you are away but you have questions, write those down too. Bring your notebook so that you can be like, hey, I thought about this and I it'll give clarity and it'll give peace to, you know, knowing what's going on and processing it better. Just communication, writing things down, and knowing that we always are going to do what's in the best interest for you and your baby, even if it doesn't feel like it. Because I'm sure, like you said, I've never been on that side. My
Mm-hmm.
babies, I'm very thankful. Um, though they were both required NICU attention at the deliveries because that's the NICU nurse curse, I swear to you. Both of them had to be attended to my deliveries. My daughter had to get a little bit of resuscitation.
Oh,
Um,
really?
Yep.
We'll talk about it.
Yeah, we'll talk about it. They never had to do a stay in the NICU, so I understand that I don't know 100% what that feels like.
Yeah,
But
that was really
we
helpful.
want what's best for you and your baby. We really, really do. We don't want to keep your baby at the hospital. We want them home to you in the comfort of your four walls of your house. And we're doing everything in our power to make that happen and create that loving family dynamic as safely as possible and as soon as possible. But sometimes the timeline is a little bit out of our control.
Yeah, this is super helpful, Sam. So,
Really?
and I
Yes.
have like so many questions that are unrelated to this, or I guess like they are related, but it taps into like another side of what I'm doing with Rooted, which is like more for women that are not
Mm.
mothers yet, right? And I knew that this episode was very much going to be helpful to the mothers because,
Hmm.
or like pregnant women. But like as you're talking, there's so many things that come up that have to do with mentality, mindset, emotions, and all this other stuff. And that's such a big piece um, that it seems like you're encountering all the time. Like there's a level of keeping the baby alive, but then there's this whole other piece that is just like humanity. And I talk about this a lot and this whole season is actually the theme is how to survive when no one cares about you. It sounds worse than what it is, but it very much is like the plight of a mother in America right now, which they feel like no one really cares, because there's too much going on. And
Yep.
so like it's just a whole other piece where like women are coming into motherhood already like kind of mentally unwell, like they have other stuff going on and then they have a baby and then the baby ends up in neonatal ICU and you're dealing with someone who already kind of like has this victim mentality or like has like something else going on, so it's like so much harder to just explain simple things. And then even when you said that cortisol impacts your ability to process, what if the person is already super stressed before they ever enter motherhood? Or they have like an abusive
Yeah.
relationship and like all these other things. So like that's what I talk about a lot and like that's the whole point of this season. And as we get to the end, I'm like, "Oh my gosh, there's so much to unpack there." But I will just have to say part 2 maybe.
Yeah.
We'll
You
come
need
back
me for
for
part two. I'm all
yeah,
yours.
because there is so much there. And even like thinking about the women who are listening who aren't mothers yet, who want to be mothers, but are nurses. Because I have so many friends who are nurses. I think it just comes along with the territory of being me. Like I make friends who are caretakers. And like nurses are really burned out right now. Like they're leaving their jobs and choosing other things and there's a lot to unpack there too because you have like so many people who are stressed out who are working as nurses, who are working as medical professionals, and then you have people coming in who are like unwell to begin with, who are now parents, and you have these dynamics together. Like burned out nurse plus stressed out mother sounds like recipe for very difficult baby stay.
Yeah,
um
it's hard. So just making sure people know that regardless of what information they're coming from their pregnancy, and then also, did they have great prenatal care? Did they have a
hmm,
provider that was giving them education along the way? I think you can have a great provider that takes a great care of an expecting mom and does all the things clinically, but maybe just education isn't their strong suit and they
hmm,
don't have the best bedside manner, which does, as a healthcare provider myself, it does make me sad when that happens because I know some doctors are the best doctors. They could figure any case out, they will treat with the most love in their heart, but it doesn't get projected in that way.
yeah.
So, you also have to think of that. Like there could be some people that we can't control the education they get prenatally. So my biggest thing to people who are pregnant or trying to get pregnant, make sure you're talking to your prenatal providers and getting the information you need because there is so much education that you can gather before your baby comes to make you more prepared. I always
Hmm.
joke that no one is ever prepared to have a baby mentally and physically and emotionally because you just don't know what it's like to have a child till you
Right.
have it.
Right.
Your heart grows
Even when you have a
a
new
million.
baby. If you had one already, then you get a different baby and you're like, "Wait a minute."
Well, then you're like, oh, I've done this before, but then the second one or the third one or the fourth one throws you a curveball, and you're like,
Yeah.
oh, I've done this and you're
Every
different
baby is a new baby.
and you're different. The dynamic is so different.
Yeah.
So, just take advantage and educate yourself and make sure you're well informed as much as you can. It may not take the trauma out of an event that you didn't expect because we're human, we're emotional
Right.
creatures.
We're allowed to
Um,
feel.
Absolutely. But, and that's what I tell the team, if we can make any event less traumatic, if we can make it less negative, it's obviously not going to be a positive experience that they're coming to the NICU. But anything we can do to give those families those small wins with their baby, with their family, to know like, hey, you made this positive impact. This is your baby. You get to decide what can we do to help you bond. Take every small win you can, because that's what we're in it for. We may not be able to say, oh my gosh, we're ready to go home already, but we're going to have ups and downs in the NICU, and we celebrate every small victory, even like your baby pooped today. For some kids, that is hard, and we are going to
Yeah.
celebrate that there was poop in that diaper, right? And then for
Yeah.
other kids, we're going to say they were strong enough to take their first bottle or the first breastfeeding session. They may be too tired in a couple hours to do it again, but they did it now, and that's amazing.
Mm.
So, focusing on the small wins, it's better. We always say to look at the big picture, but sometimes in the NICU, I'm like, it's hard to zoom out and look at the big picture because it feels like you're so far away from discharge day. You got to zoom in and focus on the little wins that you can get, because before you know it, hindsight is 2020. And none of my primaries believe me, but I'm like, I know right now, day in and day out, this is such a struggle. But when your baby is 5, 6 years old, you're going to be like, oh my gosh, NICU felt so far away.
Mm.
And I think that's true of any traumatic event in
Yeah.
somebody's life. When you're in the thick of it, you're in the thick of it. You feel like it's never going to end. The emotions are overwhelming. You don't know how you're going to make it through. So, focusing on those little things that you can celebrate and be thankful for every day are going to get you past it. And then that way, one day you can look back and be like, holy cow, we got through it. It does seem like such a small blip in time now, but um,
Wow.
yeah, that's just the
This
biggest
is
thing.
like
Mental mindset.
this is what you're saying is literally biblical. I don't know if you know, but it's like Matthew 24, I think, says, do not worry about what you will eat or what you will drink, and don't worry about tomorrow, for tomorrow worries about itself. Right. So what
Hmm.
you're saying is really like a lesson, number one, in gratitude. And of course, like in the thick of having a baby who's sick, like we're not saying forget that, right? Of course.
Right.
But
Right.
that lesson of life is what I'm pointing out, that it's even something that you could apply just in general, that like there's a lot going on all the time, like life is chaotic and crazy and sad and happy, but you can like pick out small moments of your day and your life to just be like, wow, I'm really thankful that I could get up and walk today. Like for me, I had like this really bad injury to my neck that came out of nowhere. And like for the longest time, I couldn't just like lay down in bed. Like I just couldn't lay down in bed. I had to sit up and I had to hold my arm up and all this stuff. And like one day I laid in bed and I didn't even realize because time had passed, right? And I'm just laying there and I'm like, wait, I'm laying down. Right? Like it's such
Hmm.
a silly thing, but like in the moment you're like, "Oh my goodness, like all I wanted for so long was to like lay down."
Lay
Or like
down.
when you're pregnant and then you're not pregnant, you can lay on your stomach for the first time. You can
Yes.
lay on your
Yes.
belly and you're like, "Oh,
Yeah.
you do this again." So there's like small things
Uh-huh.
that you can be grateful for that we take for granted, or like literally just small wins like you said. So I think that's a really good place to end actually. This was helpful.
Yeah.
Uh
Happy to come on. I love to do my part wherever I can, and to
yeah.
spread awareness, make people feel better when I can,
So
ease worries.
I never know like where the conversations are gonna go. Like
Hmm.
I try my best to like prepare to give questions that I think the audience would like to ask, but I love that every single time it flows into, like I don't even have to ask some questions because they just flow nicely, and then we end up having like little life lessons and good moments. So thank you, Samantha.
You're welcome.